So I'd like also to thank the organizers for inviting me to speak today. We collaborate with the residents managing those CAR T-cell patients, so I thought that this might be a relevant subject for discussion. There's rapidly advances in the field and a lot of excitement about CAR T-cells. So I believe it's a very timely and relevant subject. So this is the outline of the talk. We'll touch base on the history of CAR T cells, how it was developed, some of the basic principles, including the types of CAR constructs and the clinical applications and indications for this treatment, and the clinical trials that led to the FDA approval, as well as some of the side effects and limitations of this treatment. And we'll touch on some of the future directions, research directions in the field, and we'll end up with some ethical, socioeconomic, and regulatory considerations that this treatment poses. And finally, for the residents, we'll end up with few cases that touch on some of the subjects that we discuss oftentimes with the residents when we're taking care of those patients. So cancer treatment has evolved throughout the years until developing multiple strategies, with each one playing a major role in the management of cancer, but oftentimes they complement each other. The oldest form of cancer treatment is surgery. Many ancient civilizations described cancer and the use of surgery to treat cancer. And basically what surgery does, it's the physical removal of the tumor and the lymph nodes, and it provides local control of the disease. It's best done when the disease has not metastasized outside the organ. And then towards the end of the 19th century, and upon the discovery of X-rays and the groundbreaking work of Marie Curie, it was realized that the use of high doses of radiation can actually destroy cancer cells and suppress their growth. And that's how radiation therapy became an important tool when you're treating cancer. And then towards the mid 20th century, it was also realized that the use of some chemicals can target the rapidly dividing cells in the body, including cancer cells. And that suppresses the growth of the tumor, but it also targets other rapidly dividing cells, including gut lining, bone marrow, hair follicles. So they tend to have a lot of side effects, and those chemicals were called chemotherapies. Towards the end of the 19th century, at the 20th century, two major categories of treatments emerged around the same time. The first one is the molecularly targeted therapies, which are drugs that target molecules that are important to the progression, survival, and spread of cancer. This field took advantage of the multiple advances in genomic medicine to identify mutations and pathways that are critical to the survival of cancer cell, and try to target those pathways and mutations. And because it's targeted, it tends to have less side effects than chemotherapy. Around the same time, the idea of harnessing the immune system to or the power of the immune system to fight cancer was crystallized, and the field of immunotherapy emerged and rapidly developed until the first approval of the first checkpoint inhibitor in 2013, and the recognition of the impact of this field by Science magazine calling immunotherapy in 2013 to be the scientific breakthrough of the year, and then up until the first approval of CAR T cells in 2017. So the idea of using the immune system to fight cancer originated in the 19th century, when German physicians made the observation that there is actually an epidemiologic association between the status of the immune system and cancer. They noted that some tumors may regress spontaneously if the patients develop a skin infection, erysipelas, which is a skin infection caused by Streptococcus. And then later on, William Cawley, who was a bone surgeon in New York hospitals, started and widely considered the father of immunotherapy, and started injecting inoperable tumors with live bacteria. And out of the thousands of patients he treated, some went on to develop complete regression of the tumor. And this is the New York Times piece describing what at the time was described as Colles toxins in 1908. But because of the lack of understanding of the mechanism of action and the concern about the infectious agents and the emergence of radiation and chemotherapy, the interest in Colles toxins dissipated until it was completely discontinued in 1960. But the interest of immunotherapy was reignited throughout the 20th century when multiple molecular and biochemical advances started to explain the connection between the immune system and cancer. For example, it became clear that if you knock out some of the genes that are important to the function of the immune system, those mice go on to develop tumors very easily. This provided finally unequivocal evidence that the immune system, particularly T cells, are important for fighting tumor cells. Another important observation that was made in the 20th century is that came from autopsy studies when it was noted that people who develop infections with Mycobacterium tuberculosis during their life tend to have lower incidence of cancer, and which triggered the interest in using an attenuated live bacterial vaccine, PCG, in the treatment of cancer, and led to multiple clinical trials that eventually led to the approval of PCG in treatment of early bladder cancer, and still one of the treatments we use in early bladder cancer. At the interferons, which are a class of cytokines, were discovered in the 1950s and became clear immediately that they can also suppress tumor growth through their immune regulatory characteristics, which led to the interest in using interferon alpha in treating cancer, and eventually led to the approval of interferon alpha in hairy cell leukemia. Similarly, interleukin-2, which is a T cell growth factor, was discovered in 1976, and through a lot of work, clinical and preclinical work, much of which was done by Dr. Michael Atkins at our institution, led eventually, but also the group at the NCI, led to the approval of interleukin-2 in metastatic carcinoma, renal cell carcinoma, and melanoma, and still one of the treatments we use in these diseases. And of course, one of the oldest forms of immunotherapy is allogeneic stem cell transplant, where much of the responses we get from allogeneic stem cell transplant are from transferring T cells from the donor to the recipient through the graft. And those T cells are responsible for what we call graft versus leukemia effect, or graft versus tumor effect, which is probably what causes long-term remissions in hematologic malignancies after allogeneic stem cell transplant. So the interest in immunotherapy culminated eventually in the development of three major categories of immune therapies. The first one is immune checkpoint inhibitors, which are drugs that block some conservative, evolutionary conserved negative regulators of the T cell function. These molecules here, shown in this picture, in physiologic state, they act as fine-tune the immune system and prevent overactivation, promoting self-tolerance. And with immune checkpoint inhibitors, you block those negative regulators, which will unleash the T cells, producing remarkable response rates in a variety of solid tumors. The other major category of immunotherapy is cancer vaccines, which stimulates the immune system by introducing an antigen or two into the patient's body, and that will induce the immune system to target those antigens expressed on the cancer cells, similar to how Colles toxins worked. We also have a cancer vaccine approved by the FDA for treatment of metastatic prostate cancer. And the third major category of immunotherapy is adoptive cellular therapies. The word adoptive means transferring cells to the patient. Under this category comes tumor-infiltrating lymphocytes, which is a treatment that was approved by the FDA earlier this year for the first time after 20 years of research. And that treatment is tumor infiltrating lymphocytes, or TILS therapy, where you extract lymphocytes that have already invaded the tumor, you expand them in the lab, and then you reinfuse them into the patient. The other category of adoptive cell therapies is engineered cells, under which comes CAR T cells, but also CAR NK cells and CAR macrophages. So we'll spend most of the time talking about CAR T cells, which is the other approved, FDA-approved, commercially available cellular therapy that is available. So what are CAR T cells? So CAR T cells are T cells that have been genetically engineered to produce a synthetic molecule called CAR, which stands for chimeric antigen receptor, which is a genetically engineered receptor that allows those T cells to recognize specific antigen on the cancer cell and therefore kill those cancer cells more easily. In Greek mythology, chimera is a creature that combines together the head of one animal with the body of a different animal. So similarly, the CAR molecule combines together a component of an antibody with a component of a T cell receptor. I'll show that a little later. It's a form of gene therapy because in order to manufacture those CAR T cells, you need to introduce a gene called a transgene into the genome of the T cells to be able to express this CAR molecule on the surface of the T cells. It's also a form of adoptive therapy because you're transferring cells into the patient. After establishing that T cells are important to fighting cancer, the concept of CAR molecule emerged from efforts to try to improve those cancer fighting capabilities by genetically engineering those T cells to allow them to recognize the tumor cells more easily. So in 1987 and 1982, Japanese researchers and later Israeli researchers introduced the concept of T-body, which was a hybrid protein that combined together a component of an antibody, which is the antigen targeting component of the antibody, with the component of a T cell receptor, which is the signaling component that initiate the signaling cascade. And that's how T-body emerged and became the early version of what eventually became known as the CAR molecule. And the second step was to prove that if you transfect T cells with those hyperproteins, they will be expressed on the surface of those T cells, but also more importantly, they're functional, meaning they're able to initiate a signaling cascade even without having to interact with major histocompatibility molecule, unlike classic T cell receptor, which interaction with major histocompatibility molecule is very important. And that's how the first generation of CAR T cells emerged, or CAR T cell molecule emerged. It's basically a combination of an antigen recognition domain with T cell receptor domain. And this proved the concept that you can actually genetically engineer T cells. However, the clinical activities of those early first generation CAR molecules was very modest. And that was mainly because those cells did not expand or proliferate or even last long enough to produce clinical activity. So in order to enhance the activation and proliferation of those CAR T cells, the concept of second generation CAR T cells was introduced, where you add co-stimulatory molecule to the CAR T cell molecule, and that sends a secondary signal that enhances the activation and proliferation of CAR T cells. So all the commercially available FDA-approved CAR T cell products that we use in the clinic are second generation CAR T cell products. Third generation CAR T cell is simply adding a second co-stimulatory molecule. So you have two, and then fourth generation and fifth generation are again still experimental, and basically you engineer those CAR molecules to allow the CAR T cell to produce specific cytokines such as interleukin-2, which will recruit extra immune cells and activate those immune cells, which is very advantageous in solid tumors, where the early versions of CAR molecules did not produce a lot of responses. This is just to show the structure function relationship of the CAR molecule of second generation CAR construct, which again is the main construct used in commercially available FDA approved CAR T cells therapies. The main component is the antigen targeting domain, which is derived from an antibody. The second most important domain is the signaling domain. And then you have the co-stimulatory domain, which sends the secondary signal that enhances the activation and proliferation of those CAR T cells. An important step of manufacturing CAR T cells is the gene delivery of the transgene into the T cells. This is a critical step in manufacturing those CAR T cells. We have multiple methods that can be used to manufacture those CAR T cells. They vary in efficiency, their way of integrating the transgene into the genome, and they have different off-target effects. The most commonly used method is viral vector-based, where you use lentiviruses or retroviruses to do the genetic modifications. Basically, this method takes advantage of the fact that those viruses are able to integrate their DNA into the host genome. And it's again the most commonly used method. It's highly efficient. It produces stable expression of the CAR molecule, but it also has high risk of insertional mutagenesis because those viruses tend to introduce the new genetic material near transcription start site or regulatory genes. So they tend to have higher risk of secondary malignancy, which we'll touch base on. The other method that allows you to introduce the transgene into the T cell is non-viral methods, which are easier, less expensive, less mutagenic, but also less efficient and produce less stable expression of the CAR molecule. And then you have, of course, the CRISPR-Cas9 gene editing, which is very precise, allows you to decide exactly where you want to introduce the transgene in the T cells, which will overcome a lot of the challenges, particularly the mutagenesis that you see with different gene delivery methods. The ideal target for CAR T cell has to be tumor specific, so that it's expressed on the tumor, but not on the normal tissue. Otherwise, you'll see a lot of side effects from the CAR T cells. Has to be uniformly expressed on all the cells within the tumor, and ideally with across all individuals with the same tumor, which will reduce the risk of tumor escape from heterogeneous expression of the antigen, target antigen. Has to be essential to the tumor survival. So if the tumor cell tries to evade CAR T cell, this will compromise the viability of the cancer cell. Has to be accessible on the surface of the tumor cell. Intracellular antigens cannot be targeted by CAR T cells, and has to have limited antigen drift. The two antigens that are used to be targeted by the commercially available CAR T cells are CD19 and BCMA. CD19 is an ideal target because it's expressed on all the virtually any P cell in the body expresses CD19, but none of the other tissues will express CD19. So it's an ideal target to try to redirect T cells against B cell malignancies. BCMA or B cell maturation antigen is an ideal target to treat multiple myeloma because it's again expressed on the plasma cells and not on normal tissues. A major research area in the field of CAR T cells, especially in solid tumors, is trying to identify targets and validate those targets, and which has proven to be very challenging, especially in solid tumors, not so much in heme malignancies. How do these CAR T cells work? Once they interact, once the CAR molecule, this is the CAR molecule on the surface of the T cells, once they interact with the antigen on the tumor cell, the target antigen, this will initiate a signaling cascade through the signaling domain of the CAR molecule. And this signaling cascade is propagated by the co-stimulatory secondary signal, which will eventually lead to the translocation of multiple transcription factors into the nucleus of the CAR T cells, which will induce the expression of a lot of genes that are important for the effector function of the T cell, including cytokine production, activation, proliferation, and ultimately releasing perforin and granzyme, which will cause cell death of the cell tumor. Manufacturing those CAR T cells is highly complicated uh, procedure and is a very meticulously controlled process, and that's the main reason why these products are highly costly. The first step, the way we manufacture those CAR T cells, the first step is to collect the mononuclear cells of the patient through an apheresis procedure, and then we ship those cells to the manufacturing company. And what they do is they isolate the T cells, they activate the T cells, and then they introduce the transgene into the T cell using a viral method in commercially available products. And once you do the transfection of the CAR molecule, they culture those cells with a cocktail of cytokines to allow those cells to multiply until they reach the therapeutic dose that is needed for effective treatment of patients. This process takes few weeks. It's not done overnight. Used to take 4 or 5 weeks. Now they're more skillful in expediting that process. So it takes about 2 to 3 weeks, depending on the product. Once this a final product is produced, then the product goes through rigorous testing to make sure that the genetic modification is accurate. The um, the uh, um, there are no contaminants in the product, and those cells are functional. And once that's done, the manufacturing company will send the final product to us, to the treating center, where we give those cells to the patients. Most of those infusion treatments are done inpatient, but many centers now are starting to do outpatient administration of CAR T cells, and we're also starting to do that here, or in the process of discussing that here. The early clinical trials that were done in the field of CAR T cells were conducted at the NCI and Sloan Kettering in early 2000, trying to target CD19 on follicular lymphoma and CLL. And like I said, those early trials produced very modest clinical activity, but they were very essential in proving the feasibility of the CAR T cell approach. And during these clinical trials, we also learned about the role of conditioning, where basically they noticed that if you treat patients with few doses of fludarabine and cyclophosphamide before you infuse the CAR T cells, then those patients go on to have better response rate compared to if you don't give them fludarabine or cyclophosphamide. And that's how conditioning became standard of care. It's the standard of care that we give those patients fludarabine and cyclophosphamide before we infuse the CAR T cells. The way it's believed that conditioning works is through depleting the endogenous lymphocytes in the patients, so that those lymphocytes do not compete with CAR T cells on growth factors, etc. But the turning point was in 2010 and 2011, when the second generation CAR T cells were produced and tested in clinical trials at the University of Pennsylvania by Carl June and his group, where for the first time we saw remarkable response rates with those second generation CAR T cells in highly refractory diseases that have failed multiple lines of therapies, sometimes 4 or 5 lines of therapies. Most of those patients had estimated survival measured in months, and they went into complete molecular remission that lasted for years. And those events were documented in an award winning documentary called Of Medicine and Miracles that is available in all streaming services. The first adult patient was William Lodwick, who had highly refractory CLL that failed, I think, 4 or 5 lines of therapies. And after one infusion of CAR T cells, he went into complete molecular remission that lasted for 10 years before he died in 2021 from COVID pneumonia. The first pediatric patient was Emily Whitehead, who had highly refractory acute lymphoplastic leukemia that failed also multiple lines of therapies, including allogeneic stem cell transplant, and had a median survival that estimated to be few months. And then after one infusion of CAR T cell, she went into complete remission, and she's now 12 years, I think, in remission in college. So this is a very highly effective therapy. Based on those trials and other trials, the FDA approved the first CD19 targeting CAR T-cell product in August 30th, 2017 for pediatric ALL. And during the following years, it approved 3 other products that all of them target CD19 for a variety of B-cell malignancies, including large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, acute lymphoplastic leukemia, and most recently, chronic lymphocytic leukemia. And in 2021, the FDA approved the first, and then later in 2022, the FDA approved 2 BCMA targeting CAR T-cell products for multiple myeloma, based on response rates that ranged in the case of B-cell malignancies between 40 and 70%, meaning that 40 or 70% of patients on clinical trials responded to this treatment. And in multiple myeloma, the response rate ranged between 40 and 80%. So the next question was, okay, so these products produce remarkable response rates initially. Are these responses durable? Meaning, do they last long term, or are they transient? And we now have 3 years and 5 years real world follow-ups, especially in large B-cell lymphoma. And we know that about 40% of patients treated with CAR T cells for a B-cell malignancy will go on to achieve long-term remission, meaning, in other words, they're cured. So this is remarkable, because we're talking about a population of patients that before CAR T cells, not only did they not have any curative therapies, but also had median survival measured in months. In acute lymphoplastic leukemia, the other indication for CAR T cells, it's hard to make any conclusion, because many of those patients end up receiving allogeneic stem cell transplant. So it's hard to tease whether the long-term remission is from a transplant versus CAR T cells. And multiple myeloma, the response rate is pretty impressive. Up to 100% will have overall response rate with a complete remission rate of 40 to 80%. But those responses, unfortunately, are not typically long-lasting, meaning the treatment is not believed to be curative in multiple myeloma, but it's definitely very effective. CLL was a CD19 targeting CAR product was approved recently for CLL, which was ironic, because CLL was one of the first diseases where CAR T cells were tested. But the response rate in this disease is not great, mainly because of the biology of the disease, where the T cells you use to start the manufacturing are probably already exhausted in those patients because of the biology of the disease, as well as the treatments that they get. What do we know about the long-term persistence of those cells? So those cells are called living medicine, because after one single infusion of CAR T cells, in some situations, those CAR T cells will persist in the body for, in this study, up to 10 years. This is one of the rare studies that we have on the clonal stability and long-term persistence of CAR T cells, where they looked at 2 patients that achieved complete molecular remission 10 years later, and they were able to detect those CAR T cells in the peripheral blood and in the tissue of the patients. But as importantly, they also described 2 phases of expansion of those CAR T cells. So it seems to be happening is early on, after the infusion of CAR T cells, the CAR T cell repertoire is dominated by CD8 CAR T cells with cytotoxic characteristics. So those are the cells that produce the initial complete remission or remission or response. But then this phase is followed by another phase where the CAR T cell is dominated by CD4 CAR T cells. And those are the cells that last for 10 years and produce and sustain the remission. And that's why this treatment is curable in some of the diseases. So the second question was, okay, so all the commercially available products were approved initially by the FDA for diseases that failed. In the case of large B-cell lymphoma, failed at least for 2 lines of therapies. In the case of myeloma, they were approved for diseases that failed 4 lines of therapy. So the second question that emerged was, do patients benefit from using those CAR products early on in their treatment, as opposed to waiting until they fail 3 or 4 or 5 lines of therapies. And in large B-cell lymphoma, we have now 3 major clinical trials that compare 3 different CAR T-cell products with the standard of care, which has been in the second-line setting, which has been since the 1980, the use of stem cell transplant. So every time a large B-cell lymphoma relapses after R-CHOP, we do salvage chemotherapy and we do stem cell transplant, because it offers them, depending on a lot of factors, about 20 to 40% of cure. So these trials compare this approach, stem cell transplant, which is the standard of care, to CAR T cells. And two of those trials, ZUMA-7 and TRANSFORM, were positive, meaning that the CAR T cells produce better remission rates and better progression-free survival compared to stem cell transplant. And in the case of ZUMA-7, we have now a survival benefit, showing that those who received axi-cell, is the name of the CAR T cell, had 8% improvement in 4-year overall survival, translating into 27% reduction of the risk of death if you treat those patients with axi-cell CAR T cells compared to standard of care, which is stem cell transplant. And that's how this treatment became overnight the standard of care in second line compared to stem cell transplant. In myeloma, similarly, we have now few trials that looked at CAR T cells versus standard of care in second line, and clearly those CAR T cells outperform standard of care chemotherapy in second line as well, and now standard of care in second line as well. Those treatments are not are very effective, but they're not completely benign. They come up with some unique toxicities that we don't see with other treatments, and those are the toxicities we admit patients to the hospital to monitor for, mainly the cytokine release syndrome, or CRS, which is an inflammatory condition where caused by the massive release of large quantities of cytokines by those activated CAR T cells after the infusion of CAR T cells. In mild forms, it causes fevers. In severe forms, it causes hypotension and hypoxia and organ damage. And we treat it with tislelizumab, and if it does not respond after a couple of doses, then we move to steroids. The other main toxicity that we see with this treatment is what we call immune effector cell-associated neurotoxicity syndrome, or neurotoxicity, simply neurotoxicity. It's a syndrome characterized by, or encompasses a variety of neurologic symptoms, range from headaches, tremors, mild confusion, all the way to seizures or brain edema. And we treat those with steroids as well. In severe cases, we have to use intrathecal chemotherapy. As a consequence of targeting CD19 on all the B cells, those patients develop B cell aplasia. The normal B cells in the body are depleted, and therefore they have hypogammaglobulinemia, and they're prone to infections. So we monitor for that by checking immunoglobulin levels monthly, and replete those with IVIG if needed, especially if they have repeated infections. Cytopenia is another major side effect of this treatment, the burden of which is being recognized increasingly. It tends to last few months after the CAR T cells. The pathogenesis is not well understood. It's burdensome to the patient, to the healthcare system, because they have to come back twice weekly. We support them with transfusion. We give them growth factors. But some of the patients on the clinical trials had profound cytopenia that actually requires stem cell boost and allogeneic stem cell transplant in order to be able to reconstitute their bone marrows. Because of this cytopenia, because of the hypogammaglobulinemia, infection is a major side effect of CAR T cells. About 50% of patients will have an infection at some point. It's usually early on after the CAR T cell infusion, but it can be seen anytime after the infusion of CAR T cells. Hemophagocytic lymphohistiocytosis, or macrophage activation syndrome, is a rare but life-threatening complication of CAR T cells. We treat it with immune suppression and chemotherapy in severe cases. And then finally, secondary malignancy is an area that is attracting a lot of attention recently after the FDA released a report in October 2023 describing 22 cases of T-cell lymphoma in those patients out of the 8,000 patients they've been monitoring. This is a gene therapy, so the FDA monitor those patients for 15 years after they're required to monitor those patients for 15 years. So out of the 8,000 patients they were monitoring, 22 developed T-cell malignancy. T-cell malignancies are extremely rare, so it's hard to imagine it's just a coincidence, but they're investigating whether this is clonally related to the CAR T-cell. Those patients are also at risk for myeloid malignancies as MDS and AML, which they are already at that risk because of the chemotherapy they get before they get to the level where they need CAR T-cells. We don't know a lot about the mechanism of resistance to CAR T cells, so I'm gonna just skip those slides for the sake of time. I'm just gonna touch on the off-the-shelf CAR T cells. So all the commercially available CAR T cells that are approved by the FDA are what we call autologous CAR T cells, meaning that we use the patient's own T cells as a starting material to manufacture those CAR T cells. And this comes with some downside. First, it's very expensive. It's time consuming. It may not be feasible because a lot of those patients got exposed to chemotherapy and they may not have enough lymphocytes to manufacture the CAR T cells. And in some of those patients, the disease is aggressive enough. They don't have the luxury to wait for 4 weeks to manufacture those CAR T cells. And that's how the idea of off-the-shelf or allogeneic CAR T cells emerged, where you use T cells from healthy donors to manufacture the CAR T cells. It's readily available for immediate use. It can be cost-effective because it reduces, or you'll be able to produce large amounts of those products, which will reduce the cost per treatment. They may produce more consistent results because those are fresh T cells that have not been exposed to different number of chemotherapies, but they also come with some challenges. First, those cells are derived from somebody else, so they can be rejected by the immune system. They can also cause graft versus host disease, multiple ways to mitigate those risks. And multiple groups are working on developing those off-the-shelf CAR T cells. And finally, when you have an ideal product, you will need to test those products against what we have right now, which is autologous CAR T cells, to prove its safety and efficacy. But it's very promising area within CAR T cells with a lot of early phase clinical trials using off-the-shelf CAR T cells. For solid tumor, CAR T cells have not been as successful. It's still experimental. Multiple early phase clinical trials, especially in glioblastoma. It's likely that we will have an FDA approval within the next 5 years for glioblastoma, which has been one of the most challenging cancers with really not many options. It's the same treatment for 20 years or 30 years. But early phase clinical trials are showing encouraging results in glioblastoma. What about the non-oncological applications of CAR T cells? So we have now few reports describing using CD19 targeting CAR T cells to try to deplete the lymphocytes in patients with refractory lupus, which led to resolution of many of the symptoms that those patients had and the organ damage as well, which eventually led to the interest in using CAR T cells in other autoimmune diseases such as multiple sclerosis and type 1 diabetes. We have also preclinical reports describing the use of CAR T cells to target fibroblast and activation protein, leading to reduction of fibrosis in mouse models of cardiac injury, improving the cardiac function. So theoretically, you can use CAR T cells to target all the diseases where the fibrosis is the main pathogenesis of the disease and improve the function of fibrotic organs. You can also use CAR T cells to target senescent cells. Senescent cells are cells that cease to cease to proliferate, but they're still metabolically active, so they can produce pro-inflammatory cytokines, and they can produce degradation enzymes that contribute or believed to contribute to a lot of chronic diseases and natural aging. So you can potentially try to target that process using CAR T cells to treat those diseases, chronic diseases or diseases that are related to age. What about other type of cells? Can you use cells other than T cells to manufacture CAR T cells? So a lot of many groups are focusing on trying to use NK cells as a starting material to manufacture CAR T cells instead of T cells. The advantage of NK cells is that they don't cause a lot of graft versus host disease. Again, a lot of early phase clinical trials for CAR NK cells in a variety of hematologic malignancies. You can also think about redirect a macrophage to phagocytose a tumor cell by introducing a CAR molecule. But this is a little more tricky because the biology of macrophages is very complicated, and you could potentially promote the growth of tumors through this approach. You can also introduce a CAR molecule into T regulatory cells, which are immune suppressive cells, to target autoimmune diseases and solid organ rejection conditions. Those treatments come with some ethical and socioeconomic considerations, mainly driven by the high cost of those products, which, by the way, exceeds hundreds of thousands of dollars, excluding hospitalization and follow-up care. So these high costs raises questions about the accessibility of these products, life-saving products, to patients from different socioeconomic backgrounds. The high cost also raises questions about resource allocations within the healthcare systems. Deciding to allocate substantial resources to one treatment can limit funding to other treatments and other healthcare resources or services. The high cost also raises questions and challenges to healthcare systems, but also regulators and insurers to develop funding models or reimbursement models where you don't unfairly burden patients. At the same time, you don't restrict the use of or the accessibility of those life-saving treatments to people who are only to people who are able to pay for those treatments. Those treatments require very specialized facilities and highly trained personnel, which may not be available in underserved and rural areas, which creates a lot of geographical disparities. And as you can imagine, those disparities also exist on the global level, where a lot of developing countries don't have access to those therapies either. There's a lot of dialogue about the balance between innovation in this area, CAR T cells, but also gene therapy and TIL therapy, where the cost actually 3 times or 4 times more than CAR T cells. So there's ongoing debate about the balance and how to maintain that balance and financially sustain the ability to be able to develop those treatments and give them to patients. There's also a huge regulatory aspect to this. Basically, this is a complicated framework that is designed to make sure this is considered gene therapy, and because of the politics of that back in the 2000 and late 1990, it's you know the regulatory authorities are required to be extremely meticulous about those gene therapies, and so they develop a complicated framework to ensure the safety, efficacy, and quality of those cells. But at the same time, they have to balance that out so they don't delay approval of potentially life-saving therapies. So in conclusion, this is a very effective treatment, offering hope to a lot of patients with hematologic malignancies, potentially solid tumors and potentially other non-oncological conditions as well. They produce high remission rates in hematologic malignancies, with a lot of research being done to expand the indications for these treatments. They have their own challenges, including the unique toxicities they come with. The research right now is focusing on there are multiple directions for research, including enhancing the efficacy of those products, reducing the toxicities, increasing the accessibility to patients worldwide. Just a few words about our program. So we give all the FDA-approved CAR T-cell products here for lymphoma, myeloma, acute lymphoblastic leukemia, and chronic lymphocytic leukemia. We continue to offer all the types of transplant, including autologous transplant for lymphoma, myeloma, but also allogeneic stem cell transplant using match-related donors, match-unrelated donors, and haploidentical donors. The only type of transplant we don't do is umbilical cord, and that's basically because it's abandoned by most transplant centers after the emergence of haploidentical transplants. Virtually any patient will have a haploidentical donor. So in this era, almost everyone has a donor. We're also involved in building a research program that is at the forefront of this cellular therapy revolution and offers patients in the DMV area access to those potentially life-saving treatments. So just a couple of cases that touch on some of the issues that we encounter when we co-managing the patients and collaborating with the residents when treating those patients. So first case is 69-year-old male, relapsed refractory diffuse large B-cell lymphoma, diagnosed 12 months ago, treated with R-CHOP, relapsed 6 months after end of therapy. Now, how do you treat it now? So this is the classic presentation for that was addressed by the ZUMA-7 and TRANSFORM studies that compared CAR T-cell to autologous stem cell transplant in second-line therapy for patients who relapse within 12 months. So this is the caveat. You have to relapse within 12 months because those patients tend to have poor outcomes with stem cell transplant. And TRANSFORM and ZUMA-7 showed better response rate, better progression-free survival, and the case of ZUMA-7, better overall survival. So the standard of care is CAR T-cell in second line. What if the patient relapses after 1 year? You still do stem cell transplant in those patients. One of the products, Liso-cel or Breyanzi, is approved for those patients when they relapse after 1 year, but the patient needs to be deemed ineligible for stem cell transplant by a transplant physician. The products that are approved for second line are Axi-cel and Liso-cel. The way we choose, basically, those products have never been and will never be compared head-to-head, but we have a lot of cross-trial comparison, and most cell therapy physicians believe Axi-cel is more effective, but it's also more toxic. So the way we choose is, especially neurotoxicity, if somebody is we think that is at high risk for neurotoxicity, they have some CNS disease. I had a patient who had aneurysm and had surgery just 6 weeks before CAR T-cell. So we choose the product that has less, that we believe has less toxicity, neurotoxicity. But there's no head-to-head comparison. The expected outcomes, about 40% of those patients who treat with CAR T-cells for B-cell lymphoma, large B-cell lymphoma, will achieve long-term remission. In other words, they're cured. In terms of age, unlike stem cell transplant, we don't have an age limit. In stem cell transplant, most transplant centers will stop giving patients myeloablative chemotherapy at the age of 70 or 75. But in CAR T-cells, we have now multiple retrospective studies that looked at CAR T-cells for elderly patients. The efficacy is the same, but they may be a little at high risk for neurotoxicity. But we don't have a limit in clinical trials. The oldest was 82 or 83. We never treated anyone older than that. In terms of comorbidities, we also tend to be more relaxed in terms of considering comorbidities compared to autologous stem cell transplant. In terms of toxicity management, other case, 58-year-old female with relapsed refractory multiple myeloma. Multiple myeloma was diagnosed at the age of 55, so 3 years ago. Progressed after multiple therapies, including proteasome inhibitors, immunomodulatory drugs, and autologous stem cell transplant. And now you're treating the patient with CAR T cells. On day 5, they develop CRS, grade 3. So there are multiple. This is a question that I get frequently from residents and fellows. There are multiple guidelines about treating and grading and treating CRS and neurotoxicity. The one we use here is the one published by the ACTCT, the Society of Cell Therapy, the American Society of Cell Therapy, but there are guidelines by ASCO, by the Society of Immunotherapy of Cancer. There's little differences between all of them, but the principles are the same. So the first step is you want to grade those CRS based on how much hypotension, how severe the hypotension is. Do they require pressors? They require fluid, how severe is the hypoxia, how much oxygen they require to treat the hypoxia. And in grade 3 and 4, oftentimes the patient end up in the ICU because they require a lot of support and frequent monitoring. We treat CRS with tocilizumab in the package insert of these products. They recommend 4 doses. We don't usually use more than 2 doses because if they don't respond to the first 2 doses, usually they are not going to respond, and we move to steroids, especially if the patient is hemodynamically unstable. 2 days later, the patient developed neurotoxicity or ICANS, which is the typical course. Usually neurotoxicity lags 1 to 2 days behind CRS. So the patient 2 days later developed ICANS, grade 2. Again, we have different grading system for ICANS. We have the I-score, we have the CAR-TOX. We're using CAR-TOX here. We're going to probably move to I-score. So grade 2 neurotoxicity manifested as confusion and expressive aphasia, and then managed with steroids with close neurological monitoring. So we always consult neurology in these cases. We check brain MRI to rule out brain edema because it has therapeutic implications. We use Keppra almost all the time in those patients to prevent seizures. And any ICANS grade 2 or higher should be managed in the ICU. Outcomes toxicity managed effectively, and patient was discharged on day 15. Another area where a lot of questions are posed by different providers in the healthcare systems is how to mitigate infection risk in those patients. So again, infection is seen in about 50% of those patients, usually during the first few months after the treatment. So 60-year-old male with relapsed refractory chronic lymphocytic leukemia, diagnosed a few years ago, failed multiple lines of therapies, treated with Liso-cel, which is the only product approved for this disease, complicated by CRS grade 2, treated with corticosteroids, discharged on a tapering dose of prednisone with ANC of 700 at the time of discharge. How do you mitigate the risk of infection in this patient? So we use a lot of antimicrobial prophylaxis. The principles are the same in hematologic malignancies, stem cell transplant, cellular therapy, Valtrex, valcyclovir or cyclovir. The main virus you're targeting by this drug is VZV or shingles because there's a high risk of reactivation if you don't, and it's reactivation is burdensome to the patient. So we use valcyclovir or acyclovir routinely in those patients. It's pretty benign drugs. They don't cause any side effects. But it's also effective against herpes type 1 and 2, which also, if you don't use acyclovir or valcyclovir, you will have a lot of cases of reactivation of herpes. We also use azoles, mostly fluconazole. The main target of that drug is Candida. A lot of those patients have a lot of risks for candidemia, so we use fluconazole. If you think the patient is at risk for mold infection or aspergillosis, then you should use the other mold-covering agents like posaconazole or Cresemba, etc. We use azoles only when the patients are neutropenic. After their neutropenia recover, we don't use azoles. Fluoroquinolones are used to prevent mainly gram-negative bacteremia, and it's only used when the patient is neutropenic. Bactrim, we use Bactrim in patients for 6 months after CAR T cell because they are slightly at high risk for PCP pneumonia. This is extrapolated from the data for stem cell transplant. Not much is known about immune reconstitution after CAR T cell, so it's just extrapolation of data from stem cell transplant. If the patient is allergic to Bactrim, then we have 3 other alternatives that don't cover for toxoplasmosis. So if the patient has positive toxoplasmosis antibodies, then you probably should stick to Bactrim. In somebody with cytopenia like this, we monitor those patients twice weekly. We use growth factors. We use transfusion as needed, but we use growth factors such as GCSF to boost their neutrophils. We check immunoglobulin levels monthly, and if they're less than 400, especially if they have repeated infections, we replete with IVIG to maintain adequate immunoglobulin levels. We also vaccinate those patients at 3 months from CAR T cells, 3 to 6 months. Again, this is extrapolated from the transplant literature. And then, of course, somebody with neutrophils of 700, if they present with a fever, that's an emergency neutropenic fever. You need to admit and start broad-spectrum antibiotics. This patient had no severe infections and remained in remission. And with that, I think I'll end, and thank you for your attention. I'm happy to take any questions.